My name is Dr. Tony Reid. I'm the CEO of EpicentRx and a professor of GI Oncology at UCSD. On this WebEx, I will talk about how to relieve tumor immunosuppression, one of the main causes of treatment resistance, using two lead molecules, RX-001, nibrozetone, and ADAPT-01 as examples. Divert shields is a common battle cry from the captain of the USS Enterprise in the TV show and movie Star Trek, when one part of the spaceship is under phaser or ray attack, which, if you've ever watched it, is almost always. Shields refer to a force field or energy field that protects fixed parts or quadrants of the spaceship from weapons like phasers or photon torpedoes, and is movable or divertible depending on the angle of attack. The problem with moving the shields from one area of the ship, say the right side, to the left side, is if the left side is taking fire, is now the right side of the ship that is exposed and therefore vulnerable. However, according to the law of conservation of energy, which is adhered to even in science fiction, power reserves are finite and hence, rather than covering the whole ship, the shield must be employed and redirected to selective areas where it is most needed. It is the same with cancer cells. Energy, or ATP, the currency of the cancer cell, reserves are not infinite and therefore must be diverted, rerouted, or reallocated depending upon the dominant form of attack for maximal protection and resistance. If that attack is in the form of chemotherapy, then the cancer cell must upregulate its drug efflux pumps, for example, possibly to the detriment of other defense mechanisms. If the attack is now changed or includes cytotoxic T cells, then the cancer must expend more energy on and react to immune evasion through immune checkpoint upregulation, for example, again, possibly to the detriment of other activities, which in theory makes the cancer cell vulnerable to attack from another form. In other words, the resistance shell game moves or develops in response to one selective pressure, say chemotherapy or checkpoint inhibition, which has the potential to make the tumor vulnerable to another form of attack. At a high level, without a detailed discussion of specific mechanisms, this action-reaction effect probably underlies the sensitization of treatment-resistant tumors by RX-01 and ADAPT-01, as we will describe. With RX-01, the tumor cell is exposed to a selective pressure that it has never encountered before. Why is RX-01 different than immunotherapy or chemotherapy and radiation? Well, for one, it's derived from rocket fuel, hence the analogy to Star Trek, and is not naturally found in the environment. 2, RX-01 repolarizes tumor-associated macrophages, or TAMs, from passive to active. RX-01 treated tumors almost always, even after only one dose, develop central necrosis and edema. As the newly polarized TAMs go on the offensive and release inflammatory cytokines and recruit other immune cells, which makes the tumor look larger even if it hasn't. This is called pseudoprogression, which is a very favorable sign because it is almost always indicates that the immune infiltration and activation. The same is true for ADAPT-01. In the face of the full-on frontal assault from the oncolytic virus combined with the loss of TGF-beta, tumors reroute all power to immune suppressive shields. This likely involves upregulation of PD-1, PD-L1, immune checkpoints, which in turn predispose to the activity of PD-1, PD-L1 checkpoint inhibitors. For the most part, tumors cannot simultaneously defend against every type of novel insult or injury. Therein lies their Achilles heel. The introduction of agents like ADAPT-01 or RX-01 with distinct, non-overlapping mechanisms of action force tumors to react and respond to these novel assaults, and that leaves them open to reattack from previously ineffective therapies. So now I'm going to present a few cases to you of phase 2 data with ADAPT-01 followed by a checkpoint inhibitor after a short priming period. This is a 73-year-old man with cutaneous angiosarcoma of the left cheek with treatment history that involves several failed attempts on pembrolizumab. This patient presented with locally advanced inoperable disease and no distant metastases. He started on treatment with ADAPT-01 on March 14th 2023, and nivolumab was added 1 month later. The dramatic clinical transformation this patient underwent is easily visible, and he continues treatment with ongoing improvement. The patient has received treatment for more than 10 months, surpassing the duration of treatment of any prior line of therapy, including first-line therapy, with combination chemotherapy and treatment with checkpoint inhibitor with chemotherapy. Moreover, the benefits in tumor reduction have been achieved without toxicity to local tissue, as seen in the images, and without systemic toxicity. This is a 68-year-old man with acromelanoma with in-transit metastases. He started treatment with ADAPT-001 on April 26, 2023, with pembrolizumab added 1 month later. The patient achieved a marked partial response despite previous progression on dual checkpoint inhibition with ipilimumab and nivolumab, and despite intolerance to treatment with herpes oncolytic virus TVAC. Remarkably, he remains on therapy with ongoing benefit. 66-year-old woman with metastatic triple-negative breast cancer and failure on pembrolizumab and nab-paclitaxel. She started treatment with ADAPT-001 on August 14, 2023, with pembrolizumab added 1 month later, and showed a partial response in both the directly injected neck tumors and in non-injected lung metastases. Okay, so now I'm going to present a few cases to you of phase 2 data with RX-01 followed by a platinum doublet for which, at the time, I was the principal investigator. This case illustrates RX-01-mediated resensitization to chemotherapy after a short priming period. In several RX-01-treated tumors, central necrosis and edema occur, leading to pseudoprogression and enlargement. This effect usually means that the tumor is primed to respond to subsequent therapies. We'll show you several examples of that next. This is a small cell lung cancer patient who initially was resistant to platinum. He received a few doses of RX-01 and the tumor grew. We did not know whether the tumor growth was secondary to pseudoprogression or peripheral progression, and he was switched over to a platinum doublet. This is one of the first patients we treated on the phase 2 trial called quadruple THEC, and no one knew what would happen. However, really to our surprise at the time, the patient experienced a partial response to reintroduction of platinum doublet. At the time, this case felt like a high-wire act, even though, in retrospect, it really wasn't. There was a high-grade neuroendocrine patient with a pancreatic metastasis. This metastasis appeared to grow after only 2 doses of RX-01. And we must tell you, this case initially scared us. As you can imagine, the patient developed a loss of appetite and severe abdominal pain, which responded poorly to analgesics and a celiac plaque. We stuck a needle in the tumor to biopsy it, and what came out was a liter of liquid sludge, after which the patient felt significantly better. The pathology report, interestingly, described the presence of only coagulative necrosis with ghost cells and no viable tumor. Another small cell lung cancer patient that was refractory to platinum in first line, and by refractory we mean he progressed on platinum. But in this case, after a short RX-01 priming period, the patient responded to the platinum doublet, which never ceases to encourage and amaze us. More examples from published case reports. We have lots of them, showing RX-01 priming followed by tumor regression. Again, the point of this is to show you that even after 1 dose of RX-01, although in this case the patient received 6 doses of RX-01, tumors are primed to respond to chemotherapy. Therefore, I will reiterate, if you see growth after 1 or 2 doses of RX-01, start the platinum doublet. Here's an example of RX-01-mediated radiosensitization from a phase 1/2 trial called Brainstorm. This trial is for brain metastasis from any primary. That is important because palliative radiation, if needed for brain metastasis, is allowed per protocol. Here's a case in the top panel of a melanoma patient with a metastasis to the brain that presented with cortical blindness. After 4 months of RX-01 plus whole brain radiotherapy, the lesion regressed to the point that the patient's sight returned. In the bottom panel is another melanoma patient with a sub-centimeter brain metastasis that completely disappeared, a complete response, after 4 months of RX-01 plus whole brain radiation therapy. Here's an example of RX-01-mediated radiosensitization from a phase 1/2 trial called Brainstorm in brain metastasis from any primary, which I mentioned because in the event that palliative radiation is needed for a brain metastasis, it is allowed per protocol. In this phase 1 trial, RX-01 was given with nivolumab to 12 patients with tumors that do not traditionally respond to checkpoint inhibitors. These include cervical, breast, uterine, ovarian, and adenoid cystic adenocarcinoma. As you might imagine, pseudoprogression occurred very often on this trial. The standard paradigm in oncology is to not treat with the same therapy after disease progression, based on the assumption that resistance has developed and that resistance is inevitable, stable, and homogeneous. Consequently, retreatment would only expose patients to toxicity without benefit. However, the introduction of sensitizing therapies like ADAPT-01 and RX-01 may encourage a paradigm switch from one and done to one and not done, along the lines of if you first don't succeed with one therapy, try again. Such a paradigm shift, if successful, would buy patients, especially metastatic patients, more of what they so desperately want and need, which is, of course, more time. Feel free to reach out with any questions.